Good afternoon, everybody. My name is Martha Summerman, and I'm the Dean of the School of Dentistry and also the Chair of the Board of the University of Washington Health Science Deans. And I'd like to welcome all of you to the 19th John R. Hogness Symposium. This symposium was established in 1979 by the University of Washington Board of Regents to honor Dr. Hogness. Dr. Hogness died in 2007. He had a distinguished career as a physician, educator, researcher, and university administrator. He served as the 26th president of the university from 1974 to 79. He was the first president of the Institute of Medicine of the National Academy of Sciences, president of the American Academy of Health Centers, vice president of the American Academy of Arts and Sciences. He was the former dean of the University of Washington School of Medicine and the medical director of the University of Washington Medical Center. The symposium objectives are to inform and to illuminate issues of healthcare policy on a national level, to involve health sciences students and all students, and to be action-oriented and inspire all those to become involved with the subject. We couldn't have been more on target with our subject and our speaker today. We all know that we need healthcare reform. And for sure, we all have our own views on how this should be accomplished. Hopefully, after Professor Cutler's real story, each one of us will be challenged to play an even greater role than currently in helping to bring about stability and security to our country's healthcare system. The 6 health science schools, School of Dentistry, Medicine, Nursing, Pharmacy, Public Health and Community Medicine, and Social Work, participate in planning this important event. And I'd like to thank the members of the Symposium Committee for their diligence and hard work in putting this outstanding program together. Now, let me introduce Dr. Peter Milgram from the 2009 Hogness Symposium Planning Committee. He's the professor of dental public health sciences and also the principal investigator of our Northwest Alaska Center to Reduce Oral Health Disparities. Dr. Milgram.
Thank you, Dr. Summerman. Before I start, those of us who knew John Hogness might appreciate this story, but a couple of months before he died, I had a chance to talk to him, and he was relating to me what President Otto, who was the president of the university before him, told him as the principal advice for the new president, and that was, stay away from fundraising. So he was a very humble and lovely guy, and he would be very touched by the fact that all of you are here today to see that, that the excitement that he had for public health and for trying to make healthcare available to everyone would be shared by so many people. He's sorely missed. David Cutler, our guest today, was one of the chief architects of President Obama's healthcare plan in his election bid, and he's been consulting with Obama and the Democrats before Obama, Clinton, and other presidential candidates, Bill Bradley, John Kerry, on healthcare issues for some time. Those of you who have read some of his work know that his studies of the impact of primary prevention, of increased quality and efficiency in the healthcare system have found their way into much of the discussion about legislation that's before Congress now. He's a professor of applied economics at the Harvard John F. Kennedy School of Government. He's not new to Washington. He served on the Council of Economic Advisors and the National Economic Council during the Clinton administration. And as I said, he's been involved in the discussions about reforming the healthcare system for some time. He's been honored for his scholarly work and singled out for his outstanding mentorship of graduate students. His work in health economics and public economics have earned him significant academic and public acclaim. His unconventional approach to the healthcare crisis focuses on the value of care received by patients rather than simply looking at total costs. We're looking forward to his insights. I can tell you that those of us on the committee and many of the students have had an opportunity to be with Professor Cutler during the day, and we are very appreciative of his generous making himself so available. So with that, I hope you'll join me in welcoming Professor David Cutler.
Thank you for the very kind introduction. I remember once my former dean introduced me to a crowd as a model professor. You know, as a model teacher and researcher and so on. And so I went home and I told my wife, I said, Mary Beth, did you know I'm a model professor? Look at me. And she got out the dictionary and showed me the definition of a model is a small replica of the original. So I am delighted to be here not as the model speaker. Actually, thank you for inviting me. I go to the other Washington a lot, and I really think it is much more pleasant to come to this Washington, and really quite informative. So thank you to the whole selection committee for having me here. I did not know Mr. Hogness, but he sounds like someone for whom healthcare and taking care of people was an absolute passion. And that exemplifies many of the best elements of medical care and what makes the medical care system great when it is great. And so it's really an honor for me to try and talk about medical care system in a symposium in honor of him. Everyone on the selection committee, of course, was quite forward-thinking when they asked me to come talk about healthcare reform, the real story, when the story is not yet done. So I think that means I'm supposed to tell you the ending. But then again, the last time people listened to economists, we nearly had a second Great Depression. So I'm not exactly sure quite what you're supposed to do, but let me start off, and I want to contrast, I want to start off with kind of what you usually hear about healthcare reform. So what do you usually hear? Well, one thing you hear is about the public option. So how many of you have read more than 25 newspaper articles about the public option? It's actually probably the only ones of you who haven't read at least 25 are the ones who got so bored after number 22 that you've decided enough already, I don't really want to read these. So you certainly hear about the public option. Death and taxes. Death panels and taxes on the rich. I have a little cartoon here. Hello, I am Graham Reaper. Welcome to another edition of Celebrity Death Panel, the hottest show in America where far-left Hollywood types decide who gets medical treatment. It is actually a little-known fact about me, or not so little known. I grew up in Los Angeles, and so I feel like I ought to be one of those far-left Hollywood types who gets to decide on medical treatment for people. And so I've been keeping a list of people who haven't been nice to me over the years, so I think I should get to send them off to the Graham Reaper. At least that was my hope back when we still thought there were death panels. Should healthcare cover abortion? Very significant issue that's been in the news a lot recently. If you read only what the newspapers and TV shows told you about healthcare, this is what you'd think healthcare reform was all about. And you would be mighty confused about why anyone actually cared, since probably we weren't ever going to have death panels anyways. And what does the public option even mean? Most of the things that people want to do, for example, co-ops, have the virtue that nobody knows what they are. which is a significant virtue if therefore nobody can be mad because everyone can think of their own version of them. And obviously the abortion issue is quite real to a number of people, but it's in some ways a bit of a side to the major issues. What I want to do is move beyond what you hear about and talk about what I think are the absolute fundamentally important issues in healthcare reform. And they actually are being dealt with in the healthcare reforms that are out there. This is not a story of real healthcare reform that we're not getting to, which is some story that people sometimes tell. Instead, I actually want to tell you the story about the subterranean issues in healthcare reform that are there and that in one fashion or another we will deal with. And what I want to try and do is talk to you about how successfully we are addressing them and what it is that it would take to be more successful. So, another quiz question. What you don't hear about healthcare reform. One of the following is not true, and I want you to tell me which one. And we'll decide by majority voting. Okay? So one of the following is not true. Number one, the US Senate proposes to spend $10 billion trying out new chronic care models and disseminating successes through Medicare. How many of you believe that that statement is not true? A few lonely hands. How many of you believe that that statement is true? Okay. A fair number of people are uncertain. They presume that this is... I think there's a common misperception that this is Florida and you don't have to vote. When I woke up this morning, I was fairly convinced I wasn't in Florida, it being slightly drizzly, windy, and dark. But then again, it's sometimes hard to know, what with global warming and everything, where you are. Okay, so that's number one. Number two. Congress is on the verge of ending its micromanagement of Medicare. How many believe that this statement is not true? And how many believe this statement is true? Most people believe this is not true. Statement number three. The Yankees are inherently better than the Red Sox. I don't know who put this in the slides. How many people believe that this one is not true? Well, as I told you, one of these three statements is not true. What I want to argue today is that the third of these is not true. That is, the Yankees are not inherently better than the Red Sox. But the first two are very interesting because, in fact, the first two most people have heard relatively little about. And so it's kind of that story that I want to deal with. So what is the real story on healthcare reform? And here in a nutshell is what I think it is. It is how do you create a better, by which I mean cheaper and higher quality healthcare system. That is, I think, what is the goal of healthcare reform. It is what all the bills are trying to get at. You may agree or disagree with how they're trying to do it, but it is what the bills are trying to get at. And it's and it is absolutely the most essential part of healthcare. And so I want to kind of tell you a story about that. Let me first, though, try and come back to what it is that we're actually arguing over and put it in a little bit of context. There really are two fundamental things going on in healthcare. One is a very, very big discussion about the role of government in the economy and in something as personal to us as healthcare. The debate about the public option is certainly about that. And let me just read two sentences here, and my guess is each of these will have at least a little bit of resonance for you. The first one is, I'll be damned if I want the government messing in my medical care. For how many people does that have at least a little bit of resonance? A few. I'll be damned if I want some private insurance company messing in my medical care. They told me that Washington was a very conservative state, but I'm not sure I believe them now. So many more people dislike the idea of some damned private insurance company messing in their medical care than some damned government messing in their medical care. But you can see where those come from. And Americans have very conflicted views about the role of government and the role of corporations and so on. And we're having discussions about that. And at many levels, I don't begrudge us having those discussions because they really hit us where we are centrally. I'm not sure I have a great way to talk about how we're going to bridge those divides. I think one way or the other we have to try and find ourselves in a comfortable place, or at least enough people have to try and find themselves in a comfortable place. The one which I want to talk a little bit more about is money. And that is the second big issue here. How can we afford to cover everybody, make it balance in the short term, and save money in the longer term? Economists, after all, think about money, so I will be an economist and try and do that. I should, of course, tell you the story about the famous economist Bob Solow, who was one of my teachers at MIT. And he won a Nobel Prize in economics, and he was talking about another famous economist, Milton Friedman of Chicago, who recently passed away, a very famous economist. And he said, all Milton Friedman ever does is he thinks about the money supply, which is true. That is all Milton Friedman ever used to do, is think about the money supply. And then Bob Solow went on to say, all I ever think about is sex, but I don't let it get into my writings. I will think about the money supply for the next little bit and talk about what's going on. And so the issue is about health systems and about how do you structure a higher quality health system. And let me just start off by showing you very, very diametrically opposed views of health systems. The first one is this movie poster from Michael Moore's Sicko. There's Mr. Moore waiting with other patients to see the doctor who have been waiting a little bit longer than they ought to be waiting. They're skeletons. And this is one perception of US healthcare. Is you can't get it when you need it and it costs too much. And the tagline above it, of course, is what seems to be the problem. That's one view. The other view is this one up here. The chart that I am showing you now is the House Republicans' depiction of the healthcare reform proposal of the House Democrats, which is something that looks like only Rube Goldberg could have put it together. And even then, it would have been a doozy of a day. Now, this follows up, of course, a famous poster 16 years earlier that the Republicans did, which was very instrumental in defeating the Clinton administration healthcare plan, which was a chart about all the new things that were created. And the question was that they implicitly and explicitly raised was, how could you possibly be in favor of a healthcare reform or a healthcare system that looks like that? Of course, Michael Moore is asking the question, how can you possibly be in favor of a healthcare system that doesn't seem to mind if people die for lack of care? And what's interesting about this is the very different perceptions that you see about what constitutes a good healthcare system. On the one hand, it would be something that takes care of people well. On the other hand, it would be something that's very simple organizationally. And so the fundamental issue that comes up here is, what would a good healthcare system look like? And there really, in terms of not less what it would look like than what it would mean to get there, there are really three sorts of aspects to it. The first part is getting everybody covered. So everybody believes that a good healthcare system would give all Americans, or essentially all Americans, access to the health system on equal terms. And so that's the first presumption. The second one is to improve the value of care. What do I mean by that? I don't actually mean just save money, although I think that's a part of it. What I mean by improve the value of care is make sure that we get more for the dollars we put into it. That where we spend money, we're really getting commensurate outcomes for it. And as I'll talk about, most of our evidence is that the value of our medical spending, while it's high in some circumstances, that is particularly if people have very acute needs and they can get access to it or new medications or so on, as a whole it is substantially less productive than we would like it to be. And then the third thing that we need healthcare to do is to address the US fiscal situation. The US government is running a budget deficit that is unheard of outside of wartime. That's because we ran a budget deficit to keep us out of a second Great Depression. However, even after the economy recovers, as everyone expects it will over the next few years, even after the economy recovers, we have a very fundamental fiscal situation, which is that revenues grow with GDP and health costs are increasing more rapidly than GDP. And so the net impact is that the claims coming out of the government are rising more rapidly than the money coming into the government, and that creates a huge, unsustainable long-term balance. The balance almost totally is due to healthcare. That is, if you took out the healthcare component, more or less the government could make do. The other big issue would be aging and Social Security, but that's actually, by the scale of healthcare, not a very big deal, not very hard to fix. The healthcare one is the one that has everybody perplexed. And so at the same time as we get everybody covered and improve the value of care, we have to set the system up in a way that over the longer term, it contributes to deficit reduction and to making healthcare and the government's fiscal position be sustainable. There are a number of people who care separately about each of these. In some sense, they're all a part of the debate. And if you look at what people are trying to do, they're trying to do all three of these at the same time. That is an incredibly hard thing to do. And it's no wonder people are having an enormous amount of trouble. The question is, how would you go about doing so? So let me take these in pieces. And what I want to do is talk about what do we know about the economics of getting everybody covered. I want to spend the most time on what do we know about the economics and the system issues associated with improving the value of care. And then I want to talk about, as a byproduct, how we can think about reform addressing the US fiscal situation. So what I want to do is talk about at least how I see these issues, both as an economist and also in terms of the policy issues that are going on now. So let me start off with getting people covered. Actually, you think this is very hard. After all, we've been trying for 70 years to get people covered in the US, and we still haven't done it. So it surely must be a very difficult problem. It turns out that technically, it is not difficult at all to figure out how to get people covered. There's absolutely no technical challenge at all in figuring out how to get people covered. Most people want health insurance. They want to be protected if they get sick. They will buy insurance if they can afford it, and there's a place they can actually go to buy it. So the things that we know are that the way you get people to buy health insurance is you make it affordable and accessible. The only group for which this isn't true is people who are 24 who know that they're immortal, and under no circumstances do they ever need to see a doctor, and their motorcycle really won't crash, which is why they're not wearing their helmet anyways. And getting those people to buy insurance can be a little bit difficult, but most everybody else would really want to. Massachusetts has shown that, my home state has shown that if you make health insurance be affordable and accessible, that is, you give subsidies to low and middle income people, and you create a common marketplace where people can buy insurance, that what you will find is that the vast bulk of people will buy insurance. In Massachusetts, health insurance coverage is about 97% of the population. Very small number of people who don't have coverage will probably go up a little bit in the recession, but fundamentally Massachusetts has figured out how to insure most everybody. It wasn't all that difficult. We made it affordable and accessible. So if it's not that difficult, why haven't we done it for 70 years? The answer is every time we've thought it was too expensive to do. And the subsidies turn out to be very expensive. And let me give you an example to show that. A typical family health insurance policy in the US today is about $14,000. Okay? So health insurance for a typical family is about $13,000 or $14,000. I want you to ask yourself the question, what income level do you think a family should be able to pay $14,000 for health insurance with no help from the government? Okay, so I want you to think about, in your mind, what income level would a family have to have? Now, the right answer surely is not $28,000. That is, you're not going to make the family spend half its income on health insurance. So what income level do you think a family should be able to pay $14,000 on its own for health insurance with no help from the government? How many people think the answer is $50,000 or below? Nobody. How many people think the answer is between $50,000 and $75,000? I got maybe 5% of the hands. How many people think it's between $75,000 and $100,000? I got maybe 40% of the hands. How many people think it's between $100,000 and $125,000? I got maybe 25% of the hands. How many people think it's above $125,000? Got a few hands. So let me take your assessment in this room that the income level at which a family needs to have in order to buy insurance on its own is about $100,000. Okay, that's what you gave me. What is the median family income in the United States? The median family income in the United States is about $50,000, which means that you want to provide subsidies to families earning twice the median income. That's 80% of the families in the United States. So I have a very small question for you. Where would you like to get the money from?
The other 20%.
Well, there are really only two choices, right? One place you can get the money is the other 20%. That's the 80-20 rule. You can take the money from 20% to give to the other 80%. The second thing you can do is you can somehow make the health insurance, make the health care that people are getting cheaper and use the savings from that to pay for coverage for those who can't afford it on their own. Those are really the only two ways. Now, the bills that are pending in Congress now do both of them. The House has a tax on higher income people. The Senate has a tax on more expensive health plans, which would approximate a tax on higher income people. There are other proposals being floated to raise the Medicare tax for people who are higher income, the Medicare payroll tax. So there's some revenue that comes from raising income just in some general way. It's got to be from the higher income people because you're not going to raise it all from middle and lower income people. But of course, you can't do that for the whole amount. You're really not going to take from 20% to give to the entire amount that you need to give to the 80%. So what you're really going to have to do is you're really going to have to lower the medical spending of the 85% of people who have health care, who have health insurance, and use the savings to pay for people. And that is the other thing that's going on here. And that brings us to the absolute fundamental central issue on which I think all of healthcare reform will live or die, which is, can we figure out how to successfully increase the value of the medical care that we receive? I want to give you the premise that I think most healthcare reformers are working from. You may or may not agree with it. I happen to agree with it. You may or may not agree with it. But it is what most people are working from, and it is the easiest way to understand what is motivating the health reform bills that are currently being discussed. The premise is that medical care is inefficiently provided, and that both lowers the quality and drives up the cost of medical care. Lots of people worry about whether we should give 78-year-olds chemotherapy when they have metastatic cancer. That's an issue where the dollars and the quality are potentially going together. That is, if you give the 78-year-old woman chemotherapy, she may be more likely to survive depending on the cancer and the chemotherapy. If you don't, she isn't. And so you're really trying to decide whether it's worth it or not. This statement is getting rid of that problem. It is saying that that's not the fundamental issue. The fundamental issue is rather that what we are doing is both inefficient in the sense that quality is lower, and it's too expensive in the sense that we could save less money. So before I go on and tell you more about, let me just do one other thing. Therefore, we should be able to improve the quality and save money by modernizing healthcare. Now, let me ask, do people agree with this premise? Probably about 80% of the hands. How many disagree? A smattering of hands. This being Florida, not everybody has to vote. The fact that you agree with this basically means that you believe one way or another we ought to be able to make health reform work. If you don't agree with this premise, there's no way you think that under the current set of reform proposals we can actually make reform work, because there's no way that we will be able to save money without fundamentally compromising the quality of care somehow. Now, you may decide it's an acceptable way, but you think that we have to be having a different discussion about rationing. And what this is saying is we in essence should put that off and have the discussion about the quality of care and the cost in a way that suggests we ought to be able to have more of both. So I strongly agree with that. I think it's the heart of healthcare reform, and I want to talk a little bit about the dimensions and what do we know about how you would actually make that happen. So one dimension is administrative expenses, which are very clearly too high relative to what they need to be. We both use more time, more people, more dollars in healthcare administration than we ought to. Here's my favorite version of that. We have more people employed in office support than we have registered nurses. We have more people employed in management, business, and finance than we have practicing physicians. Ever wonder what happened to all those middle managers you used to deal with? You remember in other industries you used to deal with middle managers? I found where they all went. They are all universally working in healthcare. So any reasonable industry has figured out how to eliminate the layers of people who are involved in administration. Healthcare is almost the only industry that has not done that. As a result, the administrative costs of just running the healthcare system are significantly higher than they need to be. By this, I don't necessarily mean some kind of a single-payer system. Even in single-payer systems, there's still someone who pulls charts from a file and sticks charts back. That is the job of a person in most doctors' offices around the world. Really, what this is going to mean is about being an information company the way that Cisco or IBM or Microsoft is an information company. Okay, and so that's the first issue, is administrative expense. The second issue, and I think it's even more important, is people using too much and too expensive acute care. I have a picture up here. Can anyone tell me what this is a picture of? I'm sorry? People are mumbling. That's a cath lab. It's a scanner in a cath lab, often useful for people who have had a heart attack or potentially prophylactically to figure out the extent of coronary blockage. This chart on the right shows you the use of catheterization facilities in the US versus Canada. These are all elderly people in the two countries. These data are a few years old, but they wouldn't fundamentally be very different now, one suspects. In the US, 35% of elderly people receive a catheterization when they have a heart attack. In Canada, it's about 7%. And then 20% of people in the US, elderly people in the US, go on to be revascularized after their heart attack, compared to about 2 or 3% in Canada. On the right, you see what difference that all makes. 30-day mortality and 1-year mortality, virtually no difference between the US and Canada. Now, there's debate about quality of life, and some studies suggest that quality of life is a bit higher in the US than it is in Canada. Other studies disagree. The point I want to make is not that in no circumstances is it appropriate to do catheterization, just that it's very, very clear that there's enormous use of technology in situations where it doesn't have to be done. Okay? And the United States provides far more, and in the wrong settings, care than we need to have. This is both people who get too much after they have an event and people for whom we did not prevent the occurrence of the event in the first place. So, what is health system modernization? It's the idea that healthcare can be made normal industry in terms of productivity growth. I've tried to think a little bit about what happens in successful industries. So think about industries that you really think of as delivering very high value. Okay? In surveys, the industry that people think of as delivering the highest value is consumer electronics, information technology. Digital this and that and so on. That's the industry that people think of as delivering the highest value. In industries that deliver the lowest value, among the industries that people think deliver the least value, health insurance is one. People don't understand what the heck it does, why it's so expensive, and what's going on there. Financial services recently is up there. People really don't understand that one. Oil and gas is one of those industries that people don't think much of. So think about what is the difference between the most admired industries and the other industries, and industries where they function well and industries where they don't. There are really three features of a productive industry. The first one is that it uses information technology. It knows what happens. As someone once put it about business, there is no business that has ever gotten better without knowing what it was doing. So successful businesses know what they're doing, why they're doing it, who's doing it, how long it takes, what it costs, who should be doing it, how well they're doing it, how to improve the process of doing it. Everything there is to know about information is known somehow. Healthcare is, by my reckoning, the most information-intensive industry in the entire economy. There is no other industry that I can think of that uses information as much as healthcare. And yet, healthcare uses information technology the least of any industry in the economy. Why it is that when information is so essential, we still write it down on paper and we store it in some back office makes absolutely no sense. Of course, we do it because of the financial incentives, but there's absolutely no reason why that happens. So that's the first issue. Successful industries are industries that use information appropriately. The second hallmark of successful industries is that they have appropriate compensation arrangements. That is, they reward workers for really creating value, not the AIG kinds of rewards. But the real rewards for saying, look, if you deliver a higher value product to your customers, then we'll reward you for that. Of course, in healthcare, we reward everything but doing a better job. In fact, the easiest way to go bankrupt in healthcare is to do such a good job that your patients don't need care. Kind of a bad way to run a healthcare system. So providers get rewarded for doing more, but not for doing better, for seeing patients, but not for making sure that their health is improved, for dealing with patients in every situation except situations where they might have to reach out to them and go beyond what happens inside the walls of their offices. Doctors, nurses, social workers, everyone is frustrated because they can't deal with people the way they want to deal with them, and the reason for that is because the compensation arrangements don't permit it. So that's the second aspect of successful businesses. The third one, which really follows from the first two, is that successful businesses empower workers to do things. In the famous Toyota model, any production line worker at Toyota can stop the line if he or she thinks that something is amiss. Why? Because they have the right information and they have the right compensation incentives. So once you've got the system set up, the key is to put the information where it belongs. We used to think that enormous headquarters were important, and now we know that, in fact, headquarters are much less important than decentralizing all the work to all the appropriate workers. Okay? That's what we know about successful industries. The thing about healthcare is that it's very poor on all of these. I shouldn't necessarily say all of these. Healthcare workers are quite empowered. But it's sort of in the wrong way. That is, they're empowered within the constraints of the system. So a nurse can do a lot, a doctor can do a lot, but they can't fundamentally change the system in a way to make it work. Okay. The consequence of that is that productivity growth is very low in healthcare compared to other industries. The industry that has had the most productivity growth is the one that people think of most highly, which is the information technology industry. The information technology industry has had productivity growth that has cost declines on the order of 6% a year. Enormous reduction in costs. Many other industries have had enormous productivity improvements. They're not just industries that you think of as high tech. Retail trade has had enormous productivity. Retail trade used to be an individual goes to a store and the quality was haphazard and the price was high and it depended on the suppliers whether the things were there or not. And think about what Walmart has done to retail trade. Not just within Walmart stores, but overall for the procurement and distribution and pricing of goods and services. Even very personalized services can benefit from productivity improvements. The average rate of productivity growth is now about 2.5% a year. Official statistics indicate that health has negative productivity growth, that is, costs are going up for the same thing. That's probably not right. We measure productivity in healthcare very poorly. Almost certainly healthcare has some productivity growth, but nobody thinks healthcare is a very productive industry. And it's got a long way to go before anyone thinks of it as an industry like agriculture even, or utilities, or retail trade, or gosh forbid, information technology, where it's something that gets more productive over time. So what will it take to modernize healthcare? Well, just coming back to the earlier discussion about the ways in which successful businesses differ from unsuccessful businesses, I think there are a few components to it. One is we're definitely going to need better information. Now, we took a big step towards this in the spring with the American Recovery and Reinvestment Act, where we allocated $30 billion towards health IT. So it's estimated that by the end of the decade, essentially all of the medical system will have been wired. The real issue is not so much now the wiring of it, because we have committed ourselves to doing that, but using the results well. And one of the things about healthcare is, it's possible to do almost anything and not get very good results for it. For a long time, my doctor had a computer on his desk. It was a very fancy paperweight, but he did have a computer. More recently, we've actually figured out how to use the computer in some meaningful way, and so that's really going to be the heart of it. Although not always, I actually just recently have been able to email my doctor, which I think is an enormous technological advance in life. Would you care to guess what share of doctors regularly email with their patients? 3% of doctors regularly email with their patients, which is smaller than the number of priests who regularly email with their parishioners. And I have been told, although I have no way of knowing this for sure, that it's smaller than the number of people who regularly email with the Lord. What I don't know is whether the Lord responds more than my doctor does to the emails that get sent. So I haven't investigated that. So the use of information technology, we're going to have to figure out, take what's there and use it better. Second is compensation arrangements. We're going to have to transform compensation. That is a big item on the agenda in the healthcare bills that are currently under discussion. I want to come back and talk a little bit about it. Third is we're going to have insurance reform. A component of administrative expense comes from insurance companies competing over how to dump sick people, which is a really sort of awful situation, spending a lot of money figuring out how not to cover someone who needs coverage. And so we're going to clearly have to get rid of that. And then the fourth component is going to have to be worker empowerment. One of the areas where the legislation is not, it tends not to be devoting a whole lot of attention are things about scope of practice rules in terms of what different kinds of providers can do, the mix of medical training, the specialty mix of physicians, and so on. They'll get a little bit of attention, but not an enormous amount of attention. Better information is the first of these. What we need to do is essentially digitize all of healthcare. It's not an issue of the standards, really. The standards are all in place to do this. For a long time, there was this debate going back and forth between Washington and the health information technology people, where the people in Washington said, we'd allocate money for docs to buy computers if we thought there were standards in place. And the health information technology people say, there are standards in place. The reason why nobody buys them is because you don't put up the money. They yelled at each other for a while. I stuck them in the same room, or technically the same phone call, and they agreed that maybe, in fact, things were there. And so we kind of got ourselves a bunch of healthcare technology money. Well, it wasn't all my doing, I should say. There was just one example of the kind of it. Now, that'll be useful in a number of different ways for changing patient encounters, what happens when the doctor goes to the patients, as well as for broader social issues in terms of learning about what we need to do and when we should do it and who should do it. So that's the first obvious thing. The second one, which I think is really most important given where we are now, is to change the compensation mix. One of the most interesting things about the bills under consideration and about what's behind the bills under consideration is that they envision fundamental changes in the compensation structure for doctors, particularly under the Medicare program, but everybody knows the idea is that once it's there under Medicare, it will spread throughout the private sector. Bundling payments, that is taking payments to one provider and merging them with payments to another provider so that the two of them have to talk to each other to get it right. Bundle payments between hospitals and doctors, between hospitals and post-acute centers, between specialists and primary care doctors. Anything you can think of bundle. The limit of it is just give the doctors a fixed amount for the year and say, you go care for the patients, don't come back and ask for any more. Stressing preventive care, including ideas in the design of insurance policies to get people to do more in preventive care, doing more to create medical home models, transitional care, anything along those lines. Pay for performance type systems where we reward doctors for doing better on either process or outcome-based measures. All of these are absolutely fundamental. In all of them, we know which direction we want to go. The interesting thing about it is how fast can we get there and will we have the tools to do so? Currently, Medicare can do some of these, cannot do many of them. What actually the legislation envisions, which I'll come to in a couple of minutes, the legislation actually envisions being able to do a whole lot more on these. While you've been reading the fights about the public option and abortion and the death panels, you've been missing an enormous amount of stuff going into how would you make the compensation arrangements throughout the medical care system be very different. Of course, if it ever got a lot of attention, it might become something that we had to fight over, which would be terrible. But what's very interesting, go back to the last election for a minute. The last election was the very first election where both major candidates, Senator McCain and Senator Obama, then Senator Obama, proposed fundamentally changing the structure of the Medicare program, and nobody yelled and screamed. That was unthinkable a few years ago, where even changing any public health care program was anathema. And now both of them proposed very major changes and nobody is yelling up and down about it. In fact, even advocacy groups for the elderly and even many physicians organizations are in favor of these kinds of changes. So huge compensation changes are on the way. And then the third would be worker organizations. And here I think there's less the government can do, but much more that private sector actors will have to do. Most organizations in the healthcare sector are very hierarchical. Here's a sort of typical hospital organization chart, very, very hierarchical flow. In fact, what we know is that that's the wrong organization structure. The right one is much flatter, where there's some kind of headquarter office and every information feeds into it and goes back out and things get circulated a lot, and so there's really no up and down. There are people attempting to do a mission. That is something, that change is going to happen in order for the system to be better. And one of the interesting things about healthcare is you can't legislate all of this. A lot of this is going to be whether the private sector decides to make it happen or not. If the private sector decides it wants to do it, we can have an enormously productive decade or two. And if the private sector doesn't, then it will be an absolute waste and we will fight about it for a lot longer. What would be the impact of doing these? Well, I think there are a few things. One is that the US, which is an outlier in terms of spending a lot and not getting a lot for it, could both spend less and get a lot more for it. Where would the U.S. be in terms of spending? My suspicion is the U.S. will always be a high spender, but could be a lot closer to what other countries spend. The US will probably not live as long, at least initially, as some of these other countries do, but it could certainly do a whole lot better in terms of life expectancy and quality of life than it does now. So my own personal expectation is that if we do things right, the US will be cheaper and better. And this will show up as productivity growth, that is money that we don't have to spend on healthcare that will be available for other purposes. You can see what the impact of these changes were in other industries. Early in the post-war era, productivity growth in the US as a whole was very high. Incomes grew by about 3% a year. Those were the golden ages. People got a lot more stuff, 2 garages for every car, that sort of thing, 10 chickens in every pot. You know the whole sort of story. Everybody was happy. TV shows were bland and boring, but everyone loved it. Then after about the early 1970s, and the oil price shocks, productivity growth just plummeted. And we had a couple of decades of almost total stagnation where productivity growth grew by 1 to 1.5% a year. The difference between productivity growth of almost 3% a year and productivity growth of almost 1% a year is roughly the difference between incomes doubling every 70 years and incomes doubling every 20 years. So it's an absolutely huge difference. And then around about the mid-1990s, productivity shot up again. And we had this absolute phenomenal era where people got employed and wages went up and people felt comfortable. In fact, even in this huge recession, productivity growth is still generally going up, even over the 2000s. The gains haven't been shared equally with workers, but they've been there nonetheless. What we know is that most industries can have enormous productivity growth, and that the industries that are leading that are the ones that have adopted those kinds of information and incentive and organizational changes that I spoke about. One of the interesting things, though, by the way, one of the cautionary stories, is that most of the computer technology that industries were relying on to improve productivity actually came about in the 1980s. It took a whole decade to figure out how to use it right. It wasn't until the 1990s that we figured out how to actually use computers to improve productivity. Bob Solow, the famous economist I was telling you about, wrote an article in the late 1980s saying that you could observe the impact of computers everywhere but in the productivity data. What would be a disaster in healthcare is if it took us a decade to figure out how to use it right. We have to be able to learn from other industries in terms of how they use things and not make the same mistakes. The first mistake that most industries made is they treated the computer like a pad of paper but with a fancier screen. It's not until you move beyond that and think about the computer and the information that it provides as really being there in real time that you can make enormous productivity gains. The other impact, so one impact would be improving the quality of the medical system. The other impact would be the long-run spending scenario. There's an organization called the Congressional Budget Office, which is in charge of forecasting federal spending. This is their chart for the impact of current trends on federal spending. This is my interpretation of the Congressional Budget Office's favorite chart, in the sense that they show it more than any other chart, so presumably it's the one they like the most. The federal government currently raises about 18% of GDP in tax revenue. That is a little bit less than what we spend now, but not an enormous amount less. And so we have somewhat of a deficit. Over the next half century, if revenues stay the same, the entirety of that 18% of GDP, the entirety of that would be taken up by Medicare, Medicaid, and Social Security. There would be no money left for defense, no money left for education, no money left for interest, for paying down all that debt that we have. We borrow money from the Chinese, in exchange they give us worthless toys. No money left for environment, no money left for anything. That clearly can't happen, but the key is, if you look at this chart, the key that we have to do is we have to lower the cost of Medicare and Medicaid, and the only way we're going to do that short of rationing is by improving the productivity, like what I was telling you about. That's CBO's favorite chart. My favorite chart is this one, which shows you that what I believe we can achieve with reform, not that we can solve the problem permanently. We've still got an aging society. We still have some increase in medical spending over time because we develop new things. But we can very substantially alleviate the problem in financing the government, as well as financing businesses and individual household budgets by having successful healthcare reform that focuses on improving value. There are various bills out there. How well do they stack up? They go by such illustrious titles as HR 3962 and S 1796. Actually, I think they stack up pretty well. In comparison to what you read a lot in the paper about how people aren't pretty happy, actually, in terms of probably the biggest remaining issue, which is the compensation changes, the bills actually do pretty good. They have commitments to payment change. They have flexibility to adjust things in mid-course. They allow for lots of experimentation. And as I say, we've already put in place enormous amounts of money for IT. So the things that the federal government really needs to do, which is to make sure the information is there and make sure the compensation arrangements are right, I think the federal government is on the verge of doing. They're somewhat weaker on these non-payment issues, particularly about the workforce. I would have loved it if we had taxed sin in these bills. I don't think we're going to tax sin in them. Although I wouldn't be surprised if a lot of state governments turn to sin taxes in the very near future. State governments are going to realize at some point that they can't cut services anymore, and they're going to have to be looking for revenue, and sin taxes are going to be an obvious way to do it. So I suspect that it'll happen at the state level first. I want to just give you two qualifications. The first comment is that this is a path, not a leap. Covering people is sort of a leap. You either put the money on the table to do it or you don't. If you've put the money out there, then you can get people covered. Congratulations, take a bow. You've done it, sit back down and relax. You've either done it or you haven't done it. This is something where what you need to do is to create a pathway by which we can improve the value of care over time. And implementation is going to be very important, both at the federal level and at the level of every individual institution in the healthcare sector, from two-person doctor's offices to enormous hospitals. So it's going to take us some time to get there. And the related point is that provider support is going to be absolutely essential. The provider community can spend the next decade fighting the government over changes, in which case it will be a completely lost decade and we will be in the same situation a decade from now that we are in now. Or the provider community can embrace change and say to the government, come on, work with me, let's figure out how to make this happen. What the administration, I think, and Congress would like to do is to have the path where folks work together. That's really what the potential is about here. My hope is that we can realize that, and that a decade from now, the medical care system will be very different from what it is now, but in a much better way. And if we do that, I think that we will have considered this the decade in which we finally solved the country's healthcare problems, or at least put ourselves on an enormously good path to solving the country's healthcare problems. I remain very optimistic, even though I'm unlikely to be on any death panel. But I remain very optimistic that we really can make an enormous improvement in our collective lives and in our collective health by undertaking the right kinds of reform, and I hope we are on the verge of doing just that. So let me end. They say that economics is the dismal science. If they heard what I was telling you, they would throw me out of the dismal scientist club. But I want to end on that optimistic note and say that I think the possibilities are really there for us to do enormous amounts of good. And I want to thank you again for having me here. It's been an absolute delight for me.